Dr. Sadnias and Dr. Saeed Qureshi and everybody for inviting us. It's always a pleasure to be here, and we are okay. We are happy traveling all the way and to be a part of the family. Okay. So first, it's just really basically about the history of EUS, and that's mainly an introduction. I want to talk a little bit about the training requirements as well, and how many centers are in Pakistan, and especially you can guide me, because the information I have, some of the information about the centers I have is from 2 years back, so you can update me on that. And with regard to history, I think Dr. Wakar probably knows better. So he has grown with the EUS, looks like. So you must be familiar with this, these type of equipment. So it was it started in mid 80s, early to mid 80s. That's when it started, and there were mechanical EUS at that time. It was like a very cumbersome, bigger machine, and Dr. Haas, he's my colleague, he used to tell me he was one of the first ones who got involved with the EUS, and it was such a hassle to do a EUS. It would take every time you tell them, he's like, every time you tell the nurse that we need to do EUS, it was just like very painful to get everything ready, and would take a really a long time to set it up. Initially, it was basically mainly diagnostic. These were a mechanical scanner. There were big scopes. Their diameter was like 13 millimeter or so. Imaging wasn't great. And as an endoscopist, we are used to white and red. We like to see blood, and as compared to the radiologist who see black and white. And changing your view from red and white to black and white, it doesn't sync together. So it was difficult, and still it's difficult for people to get used to those things. Initially, as I said, it was just diagnostic, and then linear scope came. First linear scope came in 1991, and that was, I believe, it was by Hitachi, not by Olympus, not by Fuji or anybody. It was in 1991. Olympus then made first linear scope in 1994, I believe so. And there were, then came from Olympus, the F5, Alpha 5, Alpha 10, F75. I don't know if you guys are familiar with those or that equipment or not. Then you can see that now, I think most of us most of the people have, I guess, EUME 2 and EUME 1 here, and I know in LGH, Fuji is still working, right? And then EUME 2. So initially the equipment was really big, machines big. Now it's really very compact. It gets, you can connect that to your own like a regular endoscopy screen. So it's becoming more and more easier at least. And so here is really kind of a history how the EUS developed, when it started. And actually, I think the first FNA, first FNA was performed in 1992. Anybody knows Dr. Willman, Peter Willman? Yeah, he's the first person to perform a FNA. And I believe that was a mediastinal FNA of one of the tumors. So after that, initially when it was started, we didn't know about the structures, we didn't know about the layers of and the intestinal tract, and first people were trying to figure that out, and eventually after figuring that out, then what is the therapeutic or further diagnostic use. Then, as I said, FNA, first one was in 1992. It continued to refine, continued to improve, and then eventually now there are so many applications of EUS, and we can continue, we will keep talking about that. So basically, there are two type of scopes. Those who do the EUS, most of the you do, and those who are in the stage of learning, we all know. There's a radial, there is a linear. The radial is a 360 image. The transducer, it is perpendicular to the shaft of the scope. So the way you can imagine that, it's really a CT scanner, but EUS giving a CT images. So it's the same way. As compared to radial, the linear, the scanner is parallel to the shaft of the endoscope. Is there a pointer here? So if you look here, when on the radial here, you can see the scanning is perpendicular to the shaft. But with the linear, the scanning is perpendicular to the shaft. So it's an image like this. So when the needle comes out in the center of the scope. So the needle is right in the plane of the imaging. That's why you are able to see the needle. Here, in this radial one, the needle comes out of here, and there is no ultrasonic waves around that. So that's why you are not able to see the needle, and you can't use the radial for FNA, and you can only use the linear for FNA or any type of therapy. Also, even a radial has a Doppler as well, and the linear has a Doppler capability. You can see the needle, and we can use therapeutics with the linear. So linear, when it gives a view, it gives 100 to 120 degrees. Depends on what type of system you are using. It's a Fusion, it's a Pentax, it's Olympus. Now there is a therapeutic forward view scope as well. The view of that is 90 degree only, but the camera is in the front. And I have used that when I have used a prototype actually in 2009, 2010, and I don't think there was much difference than linear. And it really hasn't picked up. People still just want to use the regular linear one than a forward view one. So here, there is you can see this is a linear right here, and this is a radial here. I think I have shown this picture before. Anybody knows what's in the middle? Which scope? Yeah, that's an EBUS scope, endobronchial ultrasound. So here you don't see my elevator there. It's a little cumbersome. I have used that. It's a smaller scope. Sometimes you can use this scope if you are really want to do a staging through the stricture and don't want to dilate. You can use this scope for staging purpose. But really, we don't use much of that except in endobronchial ultrasound. So here about the EUS uses. First thing is like about the anatomy and about the structures and the layers of the intestinal tract. The whole intestinal tract pretty much is 2 to 3 millimeter thick. So the way I even describe to the patients or anybody is it has really 4 layers to it: mucosa, deep mucosa, submucosa, muscularis propria. And and after that, either it's adventitia or serosa, depending on you are in the chest, you are in the belly. So you can clearly see those layers with the EUS. And sometimes even the muscularis propria, which is at times is the outer longitudinal inner circular layer, you can separate those as well. You can see a fibrous strand in between those in the muscularis propria. So you can clearly see that those layers, the first white mucosa, and then deep mucosa is the muscularis mucosa, then another white, which is submucosa, and then the muscularis propria. I think as we move along, there are lectures about the staging and the role of EUS in staging. Actually, when we started it, we were very enthusiastic about its role in staging, but that role is decreasing now, and it is becoming more and more therapeutic. But the one place where it still works the best is where we can see a portal vein association with the pancreatic mass. Last week, I had a case, and I told that in report I put that portal vein is involved by the tumor. The radiologist looks at the MRI, CT scan. He said, no, it's not involved. Surgeons, they look in their conference. They said it's not involved. So they take the patient for surgery, and the surgeon calls me, I hate you, because it is involving the portal vein. So that's the place where it still works the best as compared to the other modalities, and they couldn't do the surgery on that. So that, I think, is the one area, and there are other areas too, but the CT scanners and the imaging is becoming so much advanced, we can use that better probably for the staging purpose. Yeah, and that's not just for Pakistan, that's everywhere. So the radiologist here might be even much more better, and then we have a radiologist in Florida. Sometimes they can't see a 6 centimeter mass, so I don't know. Like it's a universal truth. So it happens. So you can't talk bad about radiologists. We have a wonderful radiologist in the audience. Okay. We have plenty of those. We have a lot of those. Okay. So evolution of EUS, I mentioned that its role in cancer staging is decreasing, but it still have some role. Where it really differentiates itself from the other modalities is the submucosal lesions, submucosal masses. You can't really see those with a regular imaging. You can see those on endoscopy, on CT scan, MRI. You may not be able to appreciate that, but with the EUS, you can evaluate them much better. With regard to pancreas, especially some features of chronic pancreatitis, they're going to be obviously more apparent on EUS as compared to the other imaging. Small tumors, and also diagnostic for bile duct stones as well. I don't know maybe what the miss rate usually is coded for even MRCP. Miss rate for bile duct stones is 5%, especially the very distal bile duct stones, which are close to the ampulla, and those are picked up much better with the EUS itself. So if there is a clinical picture consistent with that, MRI, or CT scan is not really a great modality for stones anyway, but MRCP or ultrasound, transabdominal ultrasound, not very helpful. So before we do the ERCP on these patients, we usually do the EUS to confirm that if they have a stone or not, because before you put them through the invasive procedure like ERCP, it's better to know that. Okay, other areas, tissue acquisition, and I have a whole lecture on that later, so that's where it has a role. And then EUS guided interventions and therapeutics, and that's the area where EUS is now just expanding exponentially. So this we'll talk later about that. Other thing with the EUS, it has ancillary functions. I don't know the UME2 we have. Here it has elastography, and you have that, and you can get those without these functions as well. But elastography, and what about the contrast you guys use here or no? We don't use it. And actually there is no contrast agent which is approved in US. Sonoview, we can use that, but the approval is not for the EUS. Correct me if I'm wrong. It's not for the EUS, it's for the cardiac use. And so Sonoview, we have used during our courses, which is a contrast agent, but it's not really approved for this purpose. So here is elastography. The only, like, if you know how to use it, well and good. I think it works more in Europe than any other country. They have more experience. Also, you cannot use a balloon with that, with the elastography. So the way I remember about elastography is there are only two colors in that. It's a green and it's a blue. Green starts with G. If it's green, G is good. Blue starts with B. If it's blue, it's bad. That's the only thing you need to know. That's it. So that's how I remember that. Then red is always good. Patient is alive. Okay, so. And the contrast is really the normal pancreas. It looks, it expands very nicely, contrast, isoechoic. And that usually, if you sit there, within 90 seconds, that would disappear. The contrast you won't see. When you give a contrast in case of really a mass, it will be all hypoechoic. It will look black. And if it's like features of chronic pancreatitis, fibrous tissue in there, then it still disappears, but it takes longer for the contrast to disappear from there. Okay. Interventions and therapeutics, the first ever use of this EUS for pseudocyst drainage, that was reported in 1992. The way they used is they used a Pentax scope at that time and just really looked at that bulge and used a small cannula just to puncture it, got a wire in there, and then used a ERCP scope for really to drain it. So that is the first time for the therapeutics it was used. Then after that, now it has taken over a lot of other therapies we use it for. We use it, these are the different things. We use it for celiac plexus block. We use it for celiac plexus neurolysis. We have a recent study reported out using a ablation catheter for neurolysis. That has better results than the alcohol, where we use alcohol for neurolysis. We have an oral presentation at DDW on that. So we can use it for that. We can do a bile duct drainage. You can do a pancreatic gastrostomy. And then rendezvous procedures with the pancreas or the bile duct itself. And we've been using it for pancreatic cyst ablation in non-surgical patients. We don't use alcohol anymore for that matter. We only use chemoembolization. It can be used for fiducial placement to guide the radiation therapy. And then now gallbladder drainage, now being used for gastrojejunostomy. Now we are using in patients with gastric bypass. If they need a ERCP and you're not able to get to the papilla with the double balloon enteroscope, you can use a EUS guided connection with a lumen opposing stent between the excluded stomach and the gastric pouch and use that track to reach the papilla. So the applications, there is no limit to that. So they keep expanding and expanding. I think I'll just skip that. This is actually maybe this was the one of the first working group recommendations, like organized group recommendations, what their goal is to achieve with the US. And that was in 2008. You can see that their main goal was high priority things were to work on celiac plexus neurolysis, pancreatic drainage, biliary drainage, and ablation of the pancreatic cyst, and we have since then we have worked a lot on those, and it has been used for other purposes as well, which are listed there, but they were considered a low priority at that time. But we're working more and more on those. So just to sum up where it really has the best role is submucosal masses. I talked about the pancreas, small tumors, chronic pancreatitis, and bile duct stones. Its role is decreasing in staging, and mostly it's being now being used for intervention and therapeutic role, and also obviously tissue acquisition. So just to give you an idea about training, how the training, GI training and advanced training that happens in US, the reason I'm mentioning that is I want to just compare that what we do in Pakistan here. So with regard to general GI fellowship, there are 368 programs in the United States. And This is information is 2 years old. Now we have almost 65 advanced endoscopy programs. At that time, there were 58. And here are the numbers for usually which are suggested by the committees that that's how many procedures you need to be able to be certified to perform these procedures. So if you look at EGDs, colonoscopies, ERCP numbers, and EUS numbers, you can see EUS 150, ERCP 200, colonoscopies also 200, and those are the numbers which we use as a guidance. But the actual numbers really, you really need 300 to 400 colonoscopies, 500 ERCPs. There is a study on that to achieve a cannulation, successful cannulation rate of more than 90%. For EUS, 350 plus EUS. I don't know, Mustafa, how many you did during your training, but I did 500 EUSs during 1 year of my training. And after 200 EUSs, then I was able to realize, okay, yeah, so there's I was able to really recognize the normal anatomy. So, and that's every day doing the same thing over and over and over again. So it's a lot of commitment on your part. It's a lot of commitment on your institution's part, your trainer's part, your mentor's part. So it's not, it is a very steep curve, but eventually it comes. And then after you have done certain numbers, where I have done thousands and thousands of those EUSs now, but still we do get stuck. We still, at times, we are struggling to figure out what structure it could be, how to approach that. Everybody gets still lost during the examination. So you don't have to be discouraged with that. And the numbers eventually they come, and you will be successful. So in advanced endoscopy fellowship, which usually is 1 year in the United States, but there are 4 programs where there is a 2 years. So I'm one of those, and I usually tell them I was really hard to train, so they have to keep me for 2 years instead of 1 year. But more time you spend, the better training you will have. So right now, in my program where we train 2 advanced fellows, each fellow gets more than 800 cases combined, ERCP and EUSs. And, but to get the same number of cases, I have to do 2 years. So I don't know, different programs have a different, so, but you really need those type of numbers to become proficient in that. Again, this information is 2 years ago. Please correct me, especially about the Pakistan. In India, there are 227 EUS centers. Centers mean machines. It's sitting somewhere somebody is using. That doesn't mean they are the teaching centers or the training centers. So training centers in India, there are 17. EUS as a part of GI training, like as a regular, 0 center. They don't like, you have to get a special training in that. It's not a part of regular GI training. And you can see the on-site cytopathology where it's available. And mostly needle shear. This is again 2 years old information. I think Boston has taken a lot of share of that market in India. And as compared to that, in Pakistan, at that time, there were 16 centers, and I have listed those. Now you please correct me, what are the numbers? Probably the same number. In, is that right? In Lahore, 5, and Rawalpindi, Islamabad. One more. Okay. So 7. So I can update that. And in Karachi and Hyderabad in Sindh, how many centers are? No. Regularly doing. 4. Okay. 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 So nothing really changed in the last 2 years, much. So that's where we are, and formal training. I have been to pretty much all the units, and really nothing against Rawalpindi, but the two formal, really where I have seen people being properly trained is either in this unit or in LGH, and there is a proper supervision. I don't know about the army, how they were doing. Okay. Okay, yeah. So these are the two really, and it's also not a part of the regular GI training. It's they have you guys have to work extra, just have to be involved, and so that's the shortcoming. That's where we need to work on, and I just brought that up. Like it's training, it requires a lot of commitment from everybody. Okay, commitment from the country itself, the government, and the institution, the teachers, and obviously the trainees as well. So, okay, I think I will stop there. This is just an overall introduction. And as we go along, there are different topics we'll talk about. We'll talk about the anatomy, the stations, and tissue acquisition, and rectal EUS. I think we have a presentation on staging, role of staging, even though that is decreasing, and then about the lumps and bumps and some solutions as well. So.
Thank you very much, Dr. Khalid. Our next two talks, we'll take the questions during the tea session, please.